if you're not practicing that skill and maybe you weren't properly taught or you've been doing it for so long, you think you're great at it, I can tell you that it's worth taking the time to reacclimate yourself with the BVM because you can only do the patient harm if you don't.
The views expressed on EMS In and Out are solely those of the hosts and do not represent any affiliate agencies or employers. This podcast is for educational discussion only. Always follow your local protocols and consult your medical direction when applying any clinical practices discussed. Hello, everyone, and welcome back to EMS In and Out. I am Kyle Goodnight, one of your co-hosts. This is Rob Moyers. How you doing, Rob?
Good. How are you, Kyle?
Great. Another one of your co-hosts. We are bringing you content that we feel is really good topics to talk about. And our last few episodes, I've had some feedback from a few people that listened, and they've complimented us, Rob. So good job on the last episode, and said that the topic. I think the one I got, the most recent one I got was the assessment episode. They said that was really good. So if you haven't listened to that yet, go back and listen. All of our episodes will be, on YouTube, or if you went to the landing page, we have a full landing page as we start building episodes. You'll be able to see them all on there. And of course, Apple, Spotify, iHeartRadio, Dizangle. There's a brand new one that the system just let me add. Never heard of it before. So I'm like, I'll add it.
Yeah, why not?
Spread the wealth. So we are going to be talking about a topic today that, as we've been doing our conversations offline at periods of times, it seems to just keep on circling back to it. And we even FaceTimed each other the other day, and I showed him one and he showed me another, and we talked about ins and outs and goods and bads about these other devices that are out there. But it's going to be what a lot of people think is the most simplest device on our vehicles, but it is actually a pretty complicated device, and we're going to go all into that, and that is the BVM, the bag valve mask. So, Rob, talk about what, you've recently just been able to look at a lot of the BVMs. I've used a lot of BVMs in my background and seen a lot of the newer ones too. So kick us off. Tell us why you think it's important for, the fourth episode to go as basic as we can about the BVM.
We've said this so many times, BLS saves lives, right? And one of the things that I've noticed dealing with some of the new BVMs is a lot of them got very small. And I think part of that idea is this push into lung protective ventilation, not over ventilating people, understanding what that does in the body, gastric distension, possible aspiration, but then the other cardiogenic effects, the problems with preload that we can affect. And so I think the idea was, okay, make them smaller so you can't overventilate. But that doesn't always work in situations where you don't have an advanced airway. I think that the skill of placing a mask on a face, opening an airway, and delivering proper ventilation is something that is so technically important that, and as somebody that teaches that to brand new people and watching the awkwardness, watching people do this, and just recently having these metrics that we can measure as far as, now we have ventilators, so you can measure volume, or things like ventilatory feedback devices that tell us how much volume we're putting into something. We didn't have those back in the day, right? So, if you're not practicing that skill and maybe you weren't properly taught, or you've been doing it for so long, you think you're great at it, I can tell you that it's worth taking the time to reacclimate yourself with the BVM because you can only do the patient harm if you don't.
Right. Oh, that's a great statement. I hope the system finds that hook. I like that. So you're absolutely right. And one of the things that is repeated over and over, and pretty much anytime the bag valve mask discussion comes up, it is always discussed as, the lowest man in the totem pole, woman on the totem pole on scene gets the responsibility of bagging that patient once it's time. Once the intubation has happened, once the supraglottic airway has been placed, once possibly, if an advanced provider is doing the, holding the mask on the face while they're doing it, a lot of times they'll pass it off to the least experienced person. And that's really not what we need to be doing because, let's talk a little bit about how complicated actually a BVM is. So, one
Yeah,
of the things that we talked about right before we hit record is if you really break it down, all the different parts and pieces that have to go correct for a BVM, a proper BVM deployment of one breath it involves your hand and how you hold the mask, your hand and how you hold the bag, your what devices could be on the BVM, like a PEEP valve, and what does a PEEP valve do, and how does a PEEP valve actually, when it's on, when does it actually work? So if you
mhm,
and just to catch up with that, you have to have a closed system for a PEEP valve to work. So if you're
yeah,
using a mask with the PEEP valve on, if you don't have a good seal, your PEEP is out the window. If you have a leak of any
sure,
sort, your PEEP is out the window. Whether that's an ET tube, the leak in the mask, between the mask and the face, or a beard,
right,
facial anomalies, not having the mask on properly. I mean, and I've worked in the hospital setting before. I walked into cardiac arrests when code blue, room 202. You go to 202 and there's a nurse holding the BVM upside down, and I'm like, here, I'll take that over, please, thank you. So shout out to all my nurses out there.
yeah,
We love you to death, but when it comes to those little nuances with respiratory, we have our we have our stories. But so it is a very complicated procedure. It really is. And, because if you give too much, you could go gastric distension, like you mentioned. If you go too little, you're not getting chest rise. And we're going to talk about that in a few minutes. If you're not holding the mask right with a one person BVM, if you don't have big enough hands, I mean, all the way down. How much more complicated? I just literally listed 5 things that I have to make sure that go perfect to make a BVM actually be as good as we want it to be and we think it's going to be, and we hand it off to someone who gets very minimal training, or has not had the repetition, or hasn't had a focused class on what all nuances are with this supposedly very simple device.
right, right. And I argue there's 2 avenues of training for BVM2. There's with and without an advanced airway, and there
Yeah,
is
absolutely.
truly 2 different
100%.
techniques. So to talk about with the
Hmm.
mask, for example, first off, um, there's your hands are doing 3 things at once. They are hopefully sealing the mask on the face. That's a whole technique in itself, and
Yep.
and I find, and we talked about this, people smashing that mask down on a face, and the
Yeah.
whole idea is to bring the face into the mask.
Right.
There's one place for pressure on the face that's right above the connection point, right up kind of by the nose. That is what the push onto the face is. The rest of it is these fingers bringing that chin up. That's one
Yep.
thing. The next thing is making sure that you actually have an open airway. Otherwise, the
Yep.
air is going to go into the place of least resistance, which is your esophagus.
Right.
Third, your hand should not be squeezing that whole bag. So,
Nope.
okay, so now those 3 techniques happening at once. Um, where are the problems? Well, you don't have a good seal. What does that become? Dead space,
Yep.
right? So even if I have ventilatory feedback device, and let's say I'm aiming for 500, well, how much of that 500 is getting in there?
Actually got in. Yeah.
Because having a ventilatory feedback device that measures dead space would be fantastic as well. You know what I mean? So there's that aspect. How do we measure it? Well, old school was breathe until you see chest rise. That might actually be still a good thing to see.
Yeah.
Like that
Absolutely.
doesn't mean because we have capnography and a ventilatory feedback device, I should not be looking at that chest. So it's kind of all encompassing. You should measure, your capnography is getting high, you're not ventilating appropriately,
Yep.
right? Your chest isn't rising, your patient's still blue, you got problems. And that kind of thought process is a little bit different when you have an advanced airway and maybe something like a ventilator. So
Hmm.
when you can really deliver air, you're not going to get much dead space or leak if you got an ET tube in, right? Or if you got a properly seated supraglottic airway. So you can really start to dial in volume. As far as like not and relying on other instruments, I guess, uh, choosy with what type of BVM you have, and we'll get into that in a little bit when we talk about volume and the need for more volume when you're losing it. But it's kind of like anytime you don't have an advanced airway, you almost have to go the same way that it's been taught for decades. I mean, it
Yeah.
really doesn't matter unless you're getting chest rise and you got a good seal.
Right. And when it comes to that, that one person BVM, you know, working it with one person.
Mhm.
Those people that have large hands have a benefit. They really do, because
Yes.
they can
Mhm.
grab more of the mask. Their hands are covering more of the mask. They can hold it on it. If you're holding that mask on that patient's face and you're tilted a little bit, you're going to leak out that other side, even with the best of the
Sure.
pillows that may be out there. So ultimately, we always talk the definitive best way is a two-hand hold, but that takes one
Sure.
clinician to hold two hands properly and focus on the mask for that time, and then somebody else squeezes the bag. Now, is that somebody else
Right.
dedicated to the bag, and are they holding the bag in the right position? That's another thing that I teach. It's not always I personally don't squeeze in the middle of the bag on like a cardiac arrest. I hold the bag near the end. I give about one
Mhm.
third of the bag with me holding it the way that I do. Now, I have techniques. I have the bag that allows me to have that technique. New bags that are introduced to me, I try to always hold it in the same format. But some bags that I've noticed and some devices that are out there that are newer on the market that aren't, that have a different system and a different look to it. My pinky, I use that pinky where that oxygen tubing basically holds it up and it allows me to have a very good proper seat on it. That doesn't have that. So you're like, okay, what do I do to change my hand position that I've used for 30 years? And then, okay, how much
Sure.
memory do I have to know to do that? So there's a lot that goes into it. And a lot of, when I've been handed, I mean, a lot of people we may not have talked about it much, but I was in the product development world for 10 years, medical sales and medical product development. I saw a lot of different things come across my desk that were the next big thing coming, right? And
Mhm.
I always approach it the same way. Show me the ins, the outs, the uglies, the good, the bad. Tell me, I want to pick it apart. I want other people to pick it apart. I took a couple of the newer BVMs that are out there in the market, and I've taken those around and gave them to clinicians, whether they be medics, whether it be respiratory therapists, and I just said, tell me all you want. Like share with me your instant thoughts. Tell me what you like, what you don't like. Don't, I am no one. I mean, I'm not selling it. I'm not representing it. I just want to be able to know if this device comes to my world, how am I going to train it? How am I going to pick apart, or how am I going to, teach and educate people when they're doing it the way that you said that you didn't like it? So I always
Right.
suggest for people to be completely honest, with what they feel about it. And I've spoke to some manufacturers about their stuff. I have. I mean, I said, hey, this was an issue. Hey, this was what was good about it. Hey, this is where we have questions. And when
Mhm.
you approach them that way and you help them with understanding, I think they may not like it, but I think they respect it, right? Because ultimately they
Sure.
want what they have on the market to work. And with the different type of ambu bags, you spoke about the volume and having, not, especially with cardiac arrest, because we want to deliver lower volumes for that lung protection. When it comes to it, a lot of the early thoughts even in my area were just get the medium pediatric or the adult small, BVM, and it doesn't have enough volume when you're like, okay, it's not a cardiac arrest, it's something else where I need to have more volume. So talk a little
Right.
bit
Right.
about what you have going on with what you've been looking at and thinking about that smaller bag is the answer, but it's not always going to be the answer. It may not be the answer.
Yeah, I do have a good team that I work with as far as, from doc down, doc, my main commissioner, the commander of education. They've, I've been playing around with some bags and stuff like that. And there are a lot of cool bags out there on the market. They all kind of have their thing that they put. And the one thing that I did notice is I do, when I need reserves, I didn't quite have them. So you have a bigger person. I know we talk about ventilation is volume based on height and gender, but when you're using a bag valve mask and you don't have the pressure of a ventilator going through, sometimes you have to give a little bit more oomph to get that chest rise going through. So needing that extra reserves in that situation until I get an advanced airway almost disqualifies some of those smaller bags, because you just don't have that reserve.
Yeah, you
So,
don't have the backup. Yeah.
right.
I can always give
I
more out of a bigger bag. I can't give more out of a smaller bag, and I can always give
right.
less out
So
of a bigger bag. So
And then what that ends up doing is when you want one BVM for everybody, because that's the other thing too. Like I take into account the people in the field, so I don't want to like try to complicate stuff for people. You know what I mean?
Mhm.
So then I kind of pivot in my thinking and like, all right, well, this is what we have, this is what we're doing. What are our pluses and minuses, and how do I try to look at this from a 2 point way? Do we train in airway and ventilation, and it kind of becomes like an all-stop shop from BVM with a mask all the way to BVM with an advanced airway, then all the way to a ventilator. And you just
Right.
kind of put all that into like a pretty decent sized training thing that I'm able to do every week in Con Ed. So if people are coming through, and so now we're focusing on technique. So now we are looking at those things where you're like, all right, proper hand placement. How do you get rid of dead space the best you
Mhm.
can? How do you hold the bag? You said you hold it there. I've seen that. I've seen people push that end in to give you
Yeah,
less
that
bag to
pops out
squeeze.
though and if I get too much
I know,
pressure, it
I
just
know.
pops
Yeah,
out the backsides. I'm like, "Oh,
right.
I don't like that
Uh,
technique," but I get it.
if you hold it from underneath, you inherently squeeze less of the bag.
Less.
I don't
Yeah,
know. I
you
don't know
do.
what that technique is. So,
Yeah.
so
I
that kind
think
of
it's
stuff.
yeah, if I can think about the mechanics of your hand, just like if you're holding it underneath, I just don't I think there's something to do physically with your hand. I mean, think about when you grip things. You don't typically,
Mhm.
maybe like a pull-up bar or something you grip underneath hand, but I there may be some sort of there could be some physiological reason why you don't compress as much with your hand underneath.
Yeah,
Sorry.
it could be. It could also be the fact that when you do it from the top, a lot of times you have that strap over, so your
Mhm.
palm onto the bag. Where when you're doing underneath, you're almost handling it with your fingers, so you
Yeah.
just have
So you
less
just yeah, yep,
dexterity going into
exactly.
the bag. So,
Right.
but at the end of the day, what are you measuring? Are you measuring simultaneously? You should be measuring chest rise, capnography, SpO2, and if you have a pulse, blood pressure, because those are the four things they're going to tell you if you're bagging correctly.
Yeah. And if you do have the ventilatory assistance devices, because there's I've seen 3 on the market,
Mhm.
and some do what you mentioned of they attest for dead space, they attest for leakage, they attest for volume in, and they register volume out. Some are
Yeah.
just speed and pressure, and some are just the volume that goes through the air as you press the bag. So the good news is that we are starting to think about this. We know that there's traumatic brain injury, ventilatory maneuvers and things that we can do with some of the ventilation assistance devices that can help us with a potential TBI or any type of head injury. So we're not doing too much hyperventilation or what have you, like the old days. But it's one of the good news is about BVM and teaching our space is there's more discussion now than there ever has been. And that is
Yeah.
because it's important and they've realized it's important. From cardiac arrest, we know that 700, 800, 900 volume is not good. You're wiping out all of that negative pressure you're trying to generate while you're doing compressions. Because if you haven't realized yet that when you're doing compressions, both phases are important. You need to get the blood out of the heart, but the phase that I feel is a little bit more important is the recoil. And the recoil, why that's important, that's the negative pressure that brings the blood back to the heart. And if you don't bring
Mhm.
blood back to the heart, whether that's speed or volume in positive pressure inside the chest, you don't have any blood to get to the brain. And that's what it's all about. So that's why we
Yeah.
tell people not to hyperventilate. We also tell people not to, put too much volume in to
Sure.
wipe out that negative pressure you're trying to build. And that's that whole conversation of lung protection ventilation comes in, because we're trying to protect the lungs. But in cardiac arrest, we're also trying to protect we're trying to, understand and respect the negative pressure we're trying to keep up inside the chest. When it comes to some of these devices that you've played with, and I know that we spoke about a couple that you use on a daily basis and others that you know of, tell us about where you feel that those could possibly help in the training world.
Well, muscle memory is great. The one thing that I take in very seriously is the ability of and all of the technology that we have now that we didn't have before. It is fantastic. Just
Right.
capnography alone, is something that is such a diagnostic tool for us sometimes. and a measurement of success, whether
Mhm.
it's, are we ventilating appropriately? You talked about lung protective ventilation. Well, now we have a mark as far as just hyperventilating to so they're obviously their brain is shut down now because we've closed all of the blood vessels in their brain. Well, now we have a mark that we can hit to.
Right.
So, or we can measure how good our chest compressions are doing. So using those tools are great.
Yeah. Yeah, exactly.
So, but one thing that I, as an EMT instructor, that's when you're taught proper BVM. That now you have 2 more years of school where you're learning drugs and what emphasis is put on it. I mean, we put emphasis on when to bag, right? When do you bag, not how to bag. And, I've taught countless scenarios, I'm sure you have too. How many of them are centered on ventilation versus it being centered on a medication situation? And the person just has to know, hey, is it time to bag or not? You know what I mean? So a lot of times I've just seen it overlooked and going through this, just trying to have that opportunity to get with people and just work on technique, work on something so basic that is so not basic, just
Mhm.
making sure that people revisit technique, re-understanding, because again,
Right.
if you don't do that properly, none
Right.
of the rest of the scenario in the real world matters. You're not going to miraculously get that patient back by giving
Right.
them, mag sulfate and everything's fine, right? You
Right.
haven't ventilated them properly for 10 minutes. They ain't gonna make it, right?
Right.
So there's a lot of things that come along with that. That
Mhm.
I there's a phrase that I have when I teach. It's called, I say, get the basics squared away. So you can
Yeah.
then buy yourself a minute, take a deep breath, and formulate your paramedic plan. Your paramedic plan should not come into account until you've got basics squared away first.
Yeah.
And that's a huge part of it that I like that we're talking about.
Right. And I do want to I want to go back to the beginning a little bit because something just hit me that I realized that another layer of the difficulty in this procedure, the BVM procedure, we spoke about all of it. There was one more that I wanted to touch base on that it really is not anything about what you're feeling and how you're holding it and how much you're doing it or it does, it involves feedback of what you are feeling inside of that, what you're feeling as you're bagging that patient, and then having the
Yeah,
courage and having the courage and the knowledge to explain what you're feeling and explain what you're getting feedback from the resistance, from the ease,
yeah,
from what however you want to call it. It is a very difficult unless you've bagged you know on a daily basis, in a 12-hour shift at a hospital and you've bagged 5 or 6 patients that day, in maybe even a half a shift, you don't really know how to explain some problems. Like, how do you troubleshoot when you're bagging somebody and all of a sudden it gets stiff? And does that basic provider know to say, "Hey guys, I don't have good compliance here." Okay, that's a
yeah,
word that may
yeah,
be over their head.
yeah.
It's getting harder to bag. Okay, what does that mean? Is it getting harder to bag where you're not seeing chest rise, or is it getting harder to bag because it's harder to press? Like what, and
Mhm.
that all comes with practice and repetition and the numbers of using that bag. And quite frankly, not every single crew is using a BVM on a per shift basis with enough time to understand and learn that, even if it's learning it inherently. So once again, that's why I wanted to emphasize we're going back to the beginning about how complicated of a device that this is, but we're handing it off to the least experienced person with possibly
Yeah.
not enough training with it, right? And
Right. And
and it
the training is the big part. Yeah.
yeah, and if you're not training on this, if we're not focusing on this training, and I get that I mean, I don't know how much. I mean, it's been a long time since I've been in a full blown paramedic school or a class like you put on with basic EMTs. But in teaching specifically, and I haven't. Last time I taught anybody about BVM is in the respiratory world was a couple of students that came through back when I was working at the hospital. I would train students that would come in, and we would get those conversations. I would work with them. I would let them bag the patient, and I wouldn't just say, okay, bag the patient and leave. I actually sat and I talked to them in their ear. I'm like, what are you feeling? Is it going in easy? Do you hear? What do you hear? Well, another thing, that's another layer. What are you listening to when you're doing a BVM?
right,
What are
right.
you hearing? Are you hearing are you hearing a gurgle? Well, what does that mean? Do I have my
Yeah,
balloon far enough up? Do I have my supraglottic seated properly? Do I have my mask properly held if I'm hearing a gurgle or a or whatever, or worse yet, here's the big one. I've had a lot of new people say when you have a PEEP valve on and you've got a closed system, I mean, you've if you haven't heard this sound before, you may not know what it is, but if you've heard this sound, you know what I mean. It goes every time you press your bag and
yeah, yeah,
it
yeah,
goes in, and then
yeah.
the exhale is and people are like,
Right.
"What's wrong with the BVM? Why is it making that noise? What's wrong with the PEEP valve?" I'm like, that's just the PEEP valve on it. That's what
That's just
it sound. It make
that's
when
what's
you got
supposed to
that
do.
means you got a good seal. And
Yeah,
that's
right.
an interpretation of what it sounds like. That's not the motion that the patient is doing.
Right, right. Yeah, that's not yeah, that doesn't mean you have, like, some sort of rails going on or something. It's
Yeah, yeah.
yeah,
It's the pressure on that PEEP valve that you're hearing the exhalation through. So, and it's funny, when you bag somebody for as much as I have in the respiratory world, you can have fun with that. Sometimes it's musical, and you can be like,
mm,
you can,
right, right.
as
It's
they're
the little
breathing
things,
out, you
man,
can
in the
kind of
music, right?
resist it.
Right, right.
So,
So,
and
and
you can do
one
it on
thing
a dummy too sometimes. Yeah.
you kinda triggered something in my brain too is, um, A,
Mm.
it is very difficult to teach people what lung sounds sound like
Oh yeah,
on each
lung
other.
sounds in general. Right. Right.
Yes. Another thing is where are you practicing with the mannequin? Is the mannequin on a table in a controlled setting, or
Right.
are you throwing that mannequin on a floor where you're going to find them? Right.
Yeah.
The majority of my patients that I remember bagging before I became an instructor were overdoses.
Mm,
Now you have to think about what's going on with that patient. They are not breathing at the moment. Eventually, they're going to start breathing again. Do we have a good metric on if our ventilations were the cause of them to turn around, or was it the Narcan? How often are we in a situation where the ventilations are the key to that patient's survival?
right.
And what was the metric that we used
Mm,
to determine whether we did right by that patient?
yeah.
It narrows it down so much that it almost becomes, again, an afterthought. We have to do this because we know the patient's apneic. You know what I
Right.
mean? But
Right.
why are they apneic? Are they also in cardiac arrest? Well, we measure cardiac arrest not by ventilations, but by ROSC. We measure,
Right.
overdoses by if they wake up. There's a whole lot of things that happen with that. And it's just, it's then it's up
Mhm.
to people like myself, you, and you're in that situation of instructing, to focus on these things, to
Mhm.
rehash those old school teaching things that have not been taught to people, have not been won over for such a long time.
Well, and we keep on thinking of stuff I said something that triggered something in your brain. You just said something that triggered in my brain. Another thing, another layer. I mean, we've already how many things of the difficulty of a BVM have we
Right.
discussed?
Right.
At least
Right.
six. No, now this is a seventh one. What happens on that patient who is spontaneously breathing but needs a BVM? Like
Yeah.
how much have people learned how to breathe with someone with a BVM? Not to push it at
Yes.
the wrong time, not and how to register when they're taking their breath in and you're not giving it too much. There is a touch to that, and it
Mhm.
involves having a little bit of a pressure on the bag so you can feel their ventilations, and then when you feel their ventilations, work with them and not overpower them and not give them too little. And that's another I mean, we're talking about a seventh and
Yeah.
eighth thing that you have to keep in mind if you're really thinking about doing good BVM, technique, delivery, understanding, troubleshooting, response. I mean, there is a lot of things that go into the BVM, and often we just hand it off to someone who has never been truly trained or has had the time behind their hands. And I'd say their hands because the hands are so important for the BVM. If your hands are not trained for the BVM and you don't have the repetition, your hands are going to be your downfall for the BVM because you're holding the mask
Yep.
wrong, you're squeezing the bag wrong, you're not feeling the resistance, you're not able to describe what you're doing. Like it is, I'm trying to paint this complicated device because I want people to realize, oh, shoot, this is complicated. I need to learn this more. I don't need this to be, oh, that's just an ambu. I just squeeze it and let things go. No, I'm
Right.
telling you, everyone, this is a very important aspect. And we are now starting to dive deeper into it. There are academies out there that actually teach you for 8 hours how to bag people properly. Those are out there in the world. And if you've not heard of one before, look it up. BVM Academy. I'm not sure the actual name of it. And this is not a plug for them whatsoever, but I do believe that it needs to be, we need to train BVM like we train in high performance CPR, period.
Yeah. Yeah. Yeah.
It's
I
important.
agree. I agree. And but I was just thinking, you're talking about somebody that's you're breathing for them, and I'm just thinking like how difficult it is to get a seal on that face of that person
Yeah.
that's panicking, that can't breathe, that you're trying to breathe for them. And you talk about resistance. We haven't even really dove into breathing through a tube for somebody. That's a whole
Right.
different thing, and the resistance can be for a completely different reason.
Yep. Could be their
We teach
lungs. It could
people.
be the size of the tube. It could be, yeah.
Could be a mucus plug if you're going through a
Yeah.
trach, or you know what I mean. There's so
Yeah,
many
it could
different
be
things.
deep. It could the ET tube could be
Yeah,
deep. You may be only
yeah,
ventilating the right side. I mean, like come on, like there's so many things to think about. I mean, that we have now listed at least 10 things that you have to clinically understand. Not only the front end, you need to understand the middle, and you need to understand the end. And
right,
just because you think that this is easy to do is
right.
not part of it, right?
Yeah, because I think what happens is when we teach them initially in EMT, um, the focus ends up being just where they place themselves, how to put the mask on, and how
Oh,
to
yeah.
squeeze it.
That's another one.
So
Yeah,
and none of
you
that
wanna
other
be to the
stuff.
side, you wanna be beside the head, I mean,
Yeah,
like you said, I mean, there was one time we had I'm trying not to viol I'm trying not to make sure that I don't, have any HIPAA violation. I'm not saying their name or anything, but we had
right.
we had a hanging and in
Mhm,
the basement, and
mhm.
they were already down, but they were basically there was no room. There was no room to deal
Yeah,
with them. And so it was really hard to extricate them to an area, but we need to start getting stuff done. So you're trying to get some things done while there's other people on scene trying to make a plan to have space. Right? Like how many times
yeah,
like okay, classic example. Oh, that lady between the bathtub and the toilet and they're not breathing. What do we do? Okay, first of all, probably going to be hard to bag properly when they're squeezed in there. So you do have to extricate them to an opening. But
sure.
sometimes there's something if you just know how to position yourself and know how to hold the bag in an upside down situation with your hand, you may be able to get some rescue breaths in. But you ought to make
Mhm.
sure you got to stay out of the way if you got to do cardiac arrest. So there is a lot of stuff that comes involved. I'm so glad you said your own positioning of where you are placing yourself around that patient. We have now listed over 10 things that you have to know, you have to have had the experience, and if you haven't had the experience, you've got to be told in training, you've got to be shared with in training. It is not an easy procedure to do. It's just not when
Yeah.
you really encompass it all.
Yeah, yeah, by no means basic at all. And
Right.
when you're talking about that unworkable scene, that's one thing that I like to touch on. When you say gloves on, scene safe. Yes, is the scene safe? Is it workable as well?
Yeah,
So you
that's
got
a
to
good, yeah.
understand, like, are you in a space that yeah, okay, fine, you're safe from gunfire, but are you safe from a back injury because you're so twerked over to try to
Worked.
get
Yep.
something for this patient? So let's just get them in a workable space, like you said, and by yourself. I mean, that couple seconds to do that, to formulate that
Yeah.
move to get yourself having the room to work is huge. And you encounter that, and we're going to talk about this in another topic when high performance CPR. When they're talking about working on scene and some of the rules that they say. I mean, they say don't even 5 minutes at least until you get an advanced airway, and not so now you
Yeah,
got to
right. Yeah,
protect.
it's HA is 6 minutes. Yeah, so but that's
Yeah,
just. I mean, I'm okay with as soon as someone once gets an advanced airway, I'm totally down with that. I just don't. I'm not stopping my compressions to let you mess around.
right,
You know.
right,
So.
right. So what options do you have? What do your different divisions have? Do they have video laryngoscopy where
Mm,
it makes it a heck of a lot easier to not stop it?
right.
But then you got to be on point with, hey, listen, you got this amount of time. right? You
Right.
got this amount
Right.
of time to try to get that tube, or does your
Mhm.
agency go for supraglottic airway right away? I mean,
Well,
you know,
and right back to the thing that the thing we've touched base on, and we're probably going to get into it. I don't think we'll get into it this episode, but I definitely want to tee it up for the next episode or a couple from now. Is your superglottics in the 30-2 situation? Nobody ever
yeah,
does 30-2 on scene. Are you kidding
but
me?
just
We
yeah,
do it in
yeah,
training, yes,
I
but I
know,
mean, actually on scene, we're doing something sooner than dealing with 30-2, right? My last
yeah,
cardiac
yeah,
arrest, we had a superglottic in, I think, before the first minute. And we never stopped compressions. We had enough people there, compressions, setting up, getting stuff on, on the patient to check their rhythm. And I look up and we've got a superglottic in place. And I'm like, yes, we now have a definitive
and
airway.
they're great. You know, everything has its limitations or
Hmm.
the potential problems. One of the things that I've noticed, like depending on what you use, like um, uh, for example, like if your company uses an eye gel, one of the things that they talk about is making sure that it's sized appropriately.
Right.
Because now, if you're
Oh,
not
huge.
sized appropriately, you know, there's
You
always
don't
risk
get a
for
seal.
aspiration, right? So then you have that potential problem of aspiration. So what do you do with that? You know, ET tube, you know, we'll talk about this at some point back and forth. You know, it's the golden paramedic standard. And, you know, I always took pride in my ET tube. For some reason, I had a problem with video laryngoscopy. I was old school flat blade guy, and I was pretty good at it. And but does that always need to be the airway? It's kind of like you have to be flexible. You have
Mhm.
to be confident
You have to
in your
critically
ET tube.
think. We talk about it all
Yeah,
the time.
right.
This is
Exactly.
if
Exactly.
anybody gets anything from our discussions, I think that's number 1, is we're trying to those listeners are out there wondering why we're talking about this stuff. This is all ammunition for you to do one thing as a paramedic, and that's critically think. If you're not
Yeah.
critically thinking, yes, we have a protocol that we follow, but if we're not critically thinking that, wait a second, this next step is actually happening now and this first step is gone, I'm not going to
Yeah.
even deal with the first step of that protocol. And critically thinking is really, I talk about it all the time in my trainings. We must learn how to critically think. If I'm asking you questions after you've told me an answer or you've had a comment, if I go into more questions with you, I'm not trying to mess you up. I'm not trying to make you look stupid. I'm trying to force you into something that you may not know that you need developed, and that's critical thinking. And
Yeah.
this BVM discussion right here, this is all the whole entire episode have been critically thinking. We started talking
Mhm.
about what happens when we don't have compliance, or we have a stiff lungs after a while. What happens if we all of a sudden it's super easy to bag. You're like, okay, what just happened? Did I blow a balloon? Did I blow a lung? Like what is happening with that? So, it's just one of those things. That whole thing is that critical thinking is everything that we want our listeners and the people that take in this content. If you don't think you need to critically think in this industry, I think you should maybe rewind and listen to again. Critical thinking is important.
Yeah, and the instructors need to figure out a way to inject that into their training.
Yeah,
And that might be the next $1 million venture is somebody that comes up with a critically thinking class for pre-hospital people.
there you go.
So that we when we talk about these topics, like, you and I will have like a brief 2-minute conversation, but like you're talking about all these things we're coming up with. It's literally just stuff on the fly as we're going through it from our experiences, from our different backgrounds, and having a passion kind of doing it, I think.
Hmm.
Um, when we talk about any type of procedure. The one thing that I do like to tell people is, the best way to do something is the way that works, because you're never going to do it perfect that time. And you learn from that one. So also reflecting on, hey, listen, I had this call. What can I have objectively done better? And that's on the provider, right? That's on
Hmm.
the provider actually giving a shit and thinking about their craft and saying, oh, you know what? I am interested in relearning the BVM. You know what I mean? And
Yeah.
and and then it's up to me as an instructor to make that fun. And I'm lucky to be able to, for the most part, I teach in groups that are small enough. Like if you go through, how to operate different types of classes based on group size. I like to have discussion groups. I'm not a much of a slideshow guy. I like to sit down with the stuff. We're going to talk about it. I'm going to have a discussion. We're going to go hands on. We're going to talk about these different things. We're going to do some scenario based stuff. Myself and the instructors that I work with, we're all really big hands on instructors. So we really like to get people like, you can talk about medications all you want. All right, well, now we're going to bust out some demo doses and you're
Right.
actually going to calculate some drip rates. You know what
Yeah,
I mean? Like we have
exactly.
those kind of instructors that I work with that, I just see when you have a buy-in in an education department. So for anybody that's listening to this that is in an education department, um, making sure that you have a well-rounded plan as far as how you
Right.
approach stuff and continue to train on it. Like ventilators, for example. Ventilators are the new thing and they come out and everybody's going to get a big training. Every department that understands what to do, you're going to get the training, you're going to get competency sign-offs, and then you're going to get it deployed. What do you do from there? Do you retrain? Like, I mean, we can't think of everything as you go in training. So then you get feedback from the field and they
Yeah.
just, they're
Yeah.
like, hey, we're finding this
And
out.
you're never gonna, especially you're never going to witness everything that you're getting trained, or of like, well, they never told me that in training. Well, some things just come about and
Right.
it's so few and far between, it's not the important stuff. But to bring that information back to someone who either taught you or knows it better than what you have because you're brand new to it, say, hey, the vent did this the other day, or the ambu bag did, or so the BVM, it's Kleenex, right?
Yes.
The,
Right.
the the
Yeah.
the BVM did this to me the other day, and the mask did this to me the other day. I mean, I had somebody come up to me the other day about pediatric CPAP. Like, we almost pediatric CPAP'd a kid the other day, and I'm like, all right, tell me more. And he went in, he started talking to me more about it, and started discussing me. And I'm sitting there smiling. He's like, why are you smiling? We didn't use it. I know you were a big proponent. And I'm like, I want you to critically think, and what you're
Yeah.
explaining is critically thinking. You knew it was there. You knew you may have to go do it, but when you tried the first step that you think, hey, this may work. Sometimes you have to jump to it, even in adults. You know that. You
Right.
witness
Right. Right.
those people. But I said, I'm just so happy that, one, you came and you talked to me and did a review with me, and I appreciate that, and I respect that, and I'm glad you did. And secondly, everything you have told me through this conversation, it told me that we're doing things right with you. He's a newer medic. He's
Mhm.
been, he was one of our basics for a while here, and then advanced to being a paramedic, and it made me happy to see someone that we saw in a green moment back a few years ago have this critical thinking as a paramedic. And it's like that day when you realize that your kids have finally figured things out, right? You're like,
Yeah. Yeah.
okay,
Right. Right.
he was critically thinking, and that's why I'm smiling. And I told him that. I'm like, listen, everything you're saying, I love the way you critically thought through this, and I appreciate you doing that, and don't ever stop doing that,
Right. Because I think he understands the why. When you
Right.
understand what pediatric CPAP does and why you do it, well, when you decide that this patient doesn't need it, you understand not only steps ahead of where you need to be, but why they would have needed it and why they don't need it.
Right.
When BiPAP was introduced, I was like, well, now we got to put every asthmatic on BiPAP. I'm like, no,
No.
every asthmatic doesn't need BiPAP, but
No.
BiPAP is for every asthmatic that needs CPAP now. So
Yeah.
you know what I mean.
Or
So
or
so
or
it's like,
potentially intubation. Yeah,
yeah,
yeah.
yeah. So BiPAP has its place, CPAP has its place. Does everybody need it? No. And we've talked about in length as far as BiPAP and CPAP and the different ways to deploy that. We don't. I mean, going back into that is we've beat that horse to death pretty much. But
Yeah.
understanding that having these tools, continuing to practice on them, continuing to be objective with yourself, I think as a provider, and then having that relationship with providers and instructors and command, and being able to say, hey, you know what, this way of training sounded great and it worked great here, but based on what we're seeing, maybe we need to adjust this or implement something
Right.
different or
Right.
whatever. And that only comes with a closed loop of people who honestly care about the job and you know actually
Yeah.
care about hand placement on a bag BVM mask. I almost
Right. Yeah.
opposite myself
Well,
there.
and here's I mean, now we're starting to approach 15 things that we have to really keep in mind about, BVM and our patients. I had a run. They were an unresponsive, but they were holding their own airway for now.
Mhm.
And they held their own airway the whole run. But what did I have prepared in the back of the truck? Plugged in, oxygen rolling, a BVM
Yeah.
in the ready position. And I was questioned about that. I'm like, because I'm a Boy Scout and I was prepared because, oh, yeah, as we're rolling them to the truck, the wife said, oh, by the way, just had surgery. He had narcotics prescribed. Did he take
Mhm.
those along with the alcohol that he had on board? I don't know. I I
Yeah.
am
There's
I on
one
the
way to find
front
out.
half? I'm critically thinking. Am I
Yeah,
on the
yeah,
front
right,
half
right.
of his respiratory decline? Or am I on the middle of his respiratory decline? Or am I already on the
Yeah,
backside of his respiratory decline where our stimulation got him to at least come around a little bit to say, oh, I need to breathe a little bit more. I don't know.
right, right.
Nonetheless, but that's another thing that, another thought process of the BVM is just, okay, when am I going to deploy it? How, what type of patient may I have to deploy this on? It's no different than somebody who has a weird cardiac rhythm, and you go, you know what, this cardiac rhythm needs the patches. We need to put patches on
Yeah,
them just in
yeah,
case.
yeah,
That's no
absolutely.
different than those unresponsive patients that are holding their airway for now. They're unknown what substance they've taken, and you don't know what part of the process they're in of when they're potentially going to go respiratory decline on you. So that's
Sure.
another
Yeah,
thing to think of.
having things like capnography helps with that, you know what I mean, that we didn't have, that long ago.
Yeah. Yeah. Yep.
I think too, I think we talked about this a little bit in the last podcast where recognizing respiratory distress versus failure is
Mhm.
is a little bit it's a little bit less concrete. We know what respiratory distress looks like.
Mhm.
Respiratory failure can look like a lot of different
A
things.
lot of different
We are
things.
very quick. We are very quick to pull out a BVM with somebody who's not moving, doesn't have a pulse. How fast are we quick to pulse that out on somebody who is, like you said, maybe at the beginning of their decline, they're getting obtunded. We're looking at that, and then now we have to talk about the breathing for somebody else. So, what is our rate? What are they breathing? What is their rate? What are we breathing at? What's the ratio? You know, it, you know. So it's almost like we're creating Syn V with a bag valve mask, basically, because
Right.
they're taking their breaths. We want to keep that seal, and they're
Right.
taking their breaths or whatever they can bring in, and then we're hitting that breath when we want to give it, right? So,
Right.
those are all
Yeah.
techniques that you can
Yeah.
how do you practice that on a mannequin?
Yeah, you don't. How do you practice that thought process on a mannequin that you don't really see what's really happening? I mean, someone could stand over and be like, "Okay, well, there was a sternal rub and he did not move at all, but it seems like he's
Right.
holding his airway." Well, what does that really mean? Is he foaming at the mouth? That was the dispatch message. Patient foaming
Right.
at the mouth, and you're like,
Yeah.
okay,
Right.
we're already, so it was just one of those things where, it was, there, the BVM, the bottom line, it is not a basic ventilatory maneuver.
Right.
That's not what it
Right.
stands for. We all know it
Right.
stands for
Right.
bag valve mask, but, it is not a basic ventilatory maneuver. It is a complicated, thought process, critical thinking, technique oriented, practice that we have to be focused on. And, I'm hopeful that people are listening to this have a new sparked interest in all the things we've said to say, well, I've never really thought of that. I just grab the bag and I push. I just grab the mask and I hold it on their face. There is the right way to do a BVM, and unfortunately many people don't do it properly because they don't, either one, they don't get the repetition, or they never had the
Mhm.
advanced training. I would just ask people to go to their training departments and say, hey, I want more BVM training. Let's talk about these kind of scenarios.
Sure. And if you're an instructor and maybe you don't feel comfortable getting into that advanced, search stuff out. There's plenty of stuff on the internet.
Yep.
Kyle, you shared something with me that I had seen that was a really great kind of a webinar that talked about some of these same things. There is stuff out there that you can seek to gain the information that you need to push on to providers as well.
Right. Right.
I think the last thing that I would like to say is, please, folks, use airway adjuncts.
Oh yeah. I mean, it's so ingrained in
This
me.
what is that, number 18? Is
Nasal,
that number
oral.
18?
Yeah.
Yeah.
Well, you know
Yeah,
what
that's
we've
another
always
one.
talked. The triple barrel. The triple barrel is poof, poof. And
Yeah,
on
right.
somebody who doesn't have a gag reflex, we do a triple barrel, nasal, mouth, when it comes to our adjuncts. But yeah, that
I
is
do.
important.
I talk about OPAs being a diagnostic tool because
Sure.
if my patient takes an OPA, unless it's an overdose and I know they're going to come around, I know what they're getting next. But what else do you need to have next to you? Well, if you have all the stuff, you
Suction.
should probably have suction with you. So
Yeah.
it's a game plan. It's almost like a plan of action of
Yeah.
like saying, okay, ventilation. I need this, that. I need to be thinking about this. My hands need to be, it's so non-basic
Yep,
of
it
a
is not a
procedure.
basic
I love it.
maneuver. It is not a
Yeah,
basic ventilatory maneuver. I don't know if anybody's ever used that before. I just made it up on the spot. So it does not
you coined it.
BVM. I
That's it.
think that's gonna. If I ever do a lecture on this, my lecture title is going to be BVM does not stand for basic ventilatory maneuver.
Right, 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 right.
Or mechanics. I don't
Absolutely.
know,
I love it.
maneuver mechanics. Yeah, whatever. So,
Yeah.
all right. Well, wow, we talked about possibly going into other topics because we didn't know if this was going to be enough, but I think it was plenty. I think
Yeah.
it's important that people really focus on this and heed our advice. Like Rob said, there's so much stuff out there. We are not saying anything that nobody else is already saying. So we're just two guys liking to have our conversations, talking about what we know from our training department, our 20 years of experience, plus years of experience in this world, and hoping that whatever nuggets you pull from this, you'll pull from our previous episodes and you'll pull from our future episodes. So, Rob, anything else before we sign off?
That's it, man. I think we really hopefully pushed bag
Yeah.
valve mask out there to the masses and maybe
Yeah.
triggered something, maybe some
Yeah.
training, maybe some thinking. I mean,
Yeah.
I guess that's what we're trying to do. Right?
The thinking is the big one. That's the part
Yeah.
that's the hardest, I think. It's you can
Yeah.
teach someone how to hold a bag. You can teach someone how hard to or how often to press it and where to press it and the feel of it because that's mechanical and it's feedback. The thought process of all the other things you have to decide on while you're doing it, before you're doing it, after you're done doing it, and reviewing what you did for that person, critiquing yourself, being humble. That's all part of the BVM world, and that's very important. So, all right, well, don't forget to like, subscribe, and share. If if you're a senior medic or a senior provider out there, and this has made you think of people that should listen to this episode, don't forget to share it with them. You don't have to call them out or put their names in the comment, although we do want you to comment. So please comment in the comment section on YouTube or wherever else you're listening to this. We will, when we see those, we will answer those and maybe even discuss it on a future podcast. So, all right, Rob,
Yeah.
thank you so much. I
All right,
appreciate
Kyle.
you always being here,
Yeah,
buddy.
good to see them.
Yep.
Yep. Be safe, everybody.
Thank you for listening to EMS In and Out. 2 systems, 1 profession, real conversations. If this episode challenged your thinking, share it with someone on your shift. And remember, keep learning, keep questioning, and always follow your local protocols and medical direction. Please like, share, subscribe, and hit that bell so you'll be notified anytime new episodes drop. And as always, stay safe out there, and we'll catch you on the next call.